Hello everyone, hope you're all doing good. In this video, I'm going to discuss about pelvic organ prolapse. I know you people are afraid, but I have made this topic much simpler and in a very simple manner we are going to discuss about the detailed anatomy of the uterus, its support and how a pelvic organ prolapse is going to happen, what are the different levels and about the management also. So let's start now. Pelvic organ prolapse. So let's see what is this term means first. So there is descent or herniation of one or more of the anterior vaginal wall, posterior vaginal wall or the cervix and sometimes even the apex of vagina. Okay, right. I want you to know about the position of uterus normally. Okay, so when we talk about the position of uterus, there is an angle called angle of anteversion, that is between the vagina and cervix, which is usually 90 degree, and there is an angle of anteflexion as well, which is between the uterus and cervix, which is going to be 120 degree. This is how a normal uterus is positioned. Okay. Now let's discuss about the anatomical support of the uterus. Anatomical support of uterus means, first one we have the ligaments and fascia. Okay, so these are going to suspend the uterus from the pelvis. Okay, here you will have the endopelvic fascia that have thickened to form the pubo-cervical ligament, then the uterosacral ligament as well as the caudinal ligament, which is also otherwise known as transverse cervical or the Macandrod's ligament. Okay, so this is a picture to show you the various ligaments that are supporting the uterus. We have the pubo-cervical ligament. Okay, that is nothing but a ligament which is present between the pubic symphysis and the cervix. Okay, and then a transverse cervical ligament which is just like that running in a transverse manner from the cervix. And then you have the uterosacral ligament that is between the uterus and it is running towards the sacrum. Okay, right. Now I want to make one important point here. Yes, broad ligament is not a support to the uterus. Okay, you can mention any ligament you know, but definitely not broad ligament. Okay, right. Now the second set of support will be from the muscles, especially the levator ani muscles. So this will maintain the organs in position. Also it maintains the tone as well. Okay, and the third support is the vagina itself because of its posterior angulation. Okay, so these are the various anatomical support of the uterus. Okay, first it's about the ligaments and the fascia. We have seen three ligaments: pubocervical ligament, uterosacral ligament and the caudinal ligament, which is also known as a transverse cervical ligament or the Macandrod's ligament. Broad ligament is not a support of the uterus, that you have to know. Levator ani muscle is a support to the uterus. It will maintain the tone, and the vagina by its angulation is also another support to the uterus, right? Yes. Now, there is a separate classification given by Delancey, okay, for the support. So, Delancey levels of support. Let's see about the 3 levels that are described by Delancey. Okay. So, level 1 includes uterosacral and caudinal ligaments. This holds the upper part of vagina and cervix, and defect in this level will be giving rise to apical prolapse. Okay, that means there can be prolapse of the vault and then descent of the cervix as well. Clear? Now, let's see about the level 2 of Delancey support. It is going to be the para-vaginal attachment of lateral vagina and endopelvic fascia to the orcus tendinous, okay, to the orcus tendinous, okay. That means that will include pubo-cervical fascia, recto-vaginal fascia and orcus tendinous fascia pelvis, okay. So, there is paravaginal attachment of the lateral vagina and the endopelvic fascia to the orcus tendinous. This will include pubocervical fascia, rectovaginal fascia and the orcus tendinous fascia pelvis, okay. So, the importance of this support is that it maintains the mid position of vagina by supporting the anterior and posterior vaginal walls, okay. So, this can result in anterior vaginal wall prolapse, which will be presenting with cystocele, or when there is posterior vaginal wall prolapse, it is going to present with, yes, rectocele. Clear? Which are the anterior and posterior surrounding structures for the uterus. Clear? Now, let's discuss about level 3 support of Delancey. This will include your perineal body, superficial and deep perineal muscles and connective tissue around the distal vagina and the perineum, okay. So, this will be supporting the urethra and the distal 1/3 of vagina and also the introitus. If there is any disturbance in this support, this can result in gapping of introitus. There can be urethral hypermobility, rectocele, or even a lax perineum as well. Clear? Now, let's see the Delancey support here. Yes. So, this is about the Delancey's supports. So, at the first level, you will be having the uterosacral ligaments as well as the caudinal ligaments, which is not shown here. And in the level 2, you will be having the endopelvic fascia that is covering the levator ani muscles, and this is going to maintain the mid portion of the vagina. And at level 3, we will be having all the perineal body, the perineal muscles, especially the deep and superficial perineal muscles, the transverse perineal muscles and all, and this will be maintaining the urethra, distal 1/3 of the vagina as well as the introitus. Okay. So, this picture will help you understand this. Okay. Right. Now, let us now come to the discussion of pelvic organ prolapse. So far, we have seen about the introduction part of pelvic organ prolapse, where I wanted to know what is pelvic organ prolapse and what are the various anatomical supports, how our uterus and cervix is placed in the anatomical position, right? Now, let's now start the discussion on pelvic organ prolapse as such. So, there are different types of classification systems given for this POP, that is pelvic organ prolapse. First, let us see a compartments wise classification. Okay. So, compartment wise classification of pelvic organ prolapse. This can happen at the anterior compartment or the middle compartment or even the posterior compartment. Okay. So, anterior compartment means it is nothing but this anterior vaginal wall prolapse. Okay. Here the upper 2/3 prolapse can be associated with cystocele and the lower 1/3 prolapse is usually associated with urethrocoele. Clear? Coming to the middle compartment, it is nothing but a apical prolapse. Okay. Here there is prolapse of uterus and the vaginal vault as well. Coming to posterior compartment, there is, yes, posterior vaginal wall prolapse, and here in the upper part it can be associated with enterocele. In the middle part it can be associated with rectocele, and in the lower part this can be associated with the lax perineum. Clear? So, this thing you have to understand. Now, let us see another classification that is given for pelvic organ prolapse, which is known as Baden-Walker halfway system of classification of pelvic organ prolapse. And here the reference point what we are going to take is the hymen. Clear? So, we have 5 grades here. Let us discuss all the 5 grades first. So, grade 0 is where there is normal position of the hymen. Okay. Grade 1 means the descent is halfway to the hymen. Okay, the structures are going to descend halfway to the hymen. Then grade 2 means descent is up to the hymen. And then grade 3 means the descent is halfway after the hymen. And finally, grade 4, where there is maximum possible descent. Okay, let me show you a picture for better understanding. So this is how happens. So the cervical cuff is there and we are taking the hymen as the reference point. Okay, this is the hymen as the reference point. First one, it is in the normal. Grade 0 means it is in the normal position. Grade 1 means it is halfway to the hymen. Grade 2 means the descent is up to the hymen. This is grade 2. And after that, halfway past hymen and when you have a maximum descent. Clear? Right. We also have another classification that was given by Shaw. So, Shaw classification of pelvic organ prolapse. Okay. Here we have 4 degrees. The first degree means there is descent of cervix into the vagina. Okay. And second degree prolapse means there is descent of cervix into the introitus. Okay. Third degree prolapse means there is descent of the cervix outside the introitus. And finally, we have the term procedentia, where all of the uterus and cervix is going to lie outside the introitus. Clear? So, this is Shaw classification of pelvic organ prolapse. Okay. Let us see the diagrammatic representation for better understanding. So, yeah. So, the grading of prolapse is according to the level of introitus. Okay. So, first one, this is normal position, whereas when you see here, there is descent of the cervix into the vagina, then the cervix is coming and touching the introitus here, right? And the next one is where the cervix is coming out of the introitus, and in procedentia, almost the whole of the uterus is lying outside the introitus. Clear? Right. And apart from this, you also have a quantification system. Okay. So, till now we have seen one fixation point or a reference point, and then we will be comparing the how much they have descent from their normal position. We have a quantification system also, which is known as POP-Q system of classification of pelvic organ prolapse. This is all about quantification. That is, we are going to measure how much descent it has happened like that. Okay. So, it quantifies the stage of prolapse. Okay. We are going to measure 9 distances and all are measured with Valsalva maneuver except your TVL. TVL is nothing but total vaginal length. Okay. We have a POP-Q grid. So, POP-Q grid means, let me draw it so that you will understand. Okay. It consists of 3 rows and 3 columns and 9 values. Okay. So, it consists of capital A, small a, AA, BA and C, then GH, PB and TBL, then AP, BP and D. Okay. So, you have to remember this. I will just explain you what are all these terms anyhow. Okay. So, it is AA, B, C. Okay. Then it is A, B and D here, and in the center you have GH, PB and TBL. Okay. So, this is POP-Q grid, right? Now, let me explain what are all these terms. AA is nothing but a point A that is taken on the anterior vaginal wall. Okay. So, that is why we give small a here. Okay, so that means anterior vaginal wall. Okay, and yeah, the same way BA means the point B that is taken on the anterior vaginal wall. What is C? Yes, it is cervix. And GH means it is genital hiatus. PB refers to perineal body. TVL means it is total vaginal length. Then AP, the same like AA, it is A point that is taken on the posterior vaginal wall. Then BP, the point B that is taken on the posterior vaginal wall. And finally, we have the point D also, which is posterior fornix. Clear? So, you have to know all these points, right? You have AA, BA, C, then GH, PB, TVL, then AP, BP and D. D is nothing but posterior fornix. Clear? Right. Now, let's see how they will be measured, how these points will be present. Okay. So, yeah. You have to know that this is the uterus. Okay. Here comes the vaginal wall, the cervix and the uterus. I am highlighting it for you to know it better. Clear? So, we have point AA, A point on anterior vaginal wall, because here you have the bladder. So, definitely this is going to be the anterior portion and it is anteversion and anteflexion. Okay. So, this is BA, right? You have the GH, which is genital hiatus, PB measurement, where you are going to measure how much perineal body is present. Then you are going to measure the total vaginal length. See, total vaginal length right from your introitus to the uppermost level of vagina. Then you have point AP, BP, you are going to point out the cervix also, and D is nothing but your posterior fornix. Clear? Now, let's see how significant is this measurement and the various points taken on the anterior vaginal wall, posterior vaginal wall and also the other points. For example, if there is any deviation in the AA and BA that is present on your anterior vaginal wall points, then there is definitely a anterior compartment prolapse, right? If there is any deviation in your AP and BP, then yes, definitely there is a posterior compartment prolapse. And when you have any deviation in the values of C, that is cervix, total vaginal length, or the posterior fornix, there is going to be an apical prolapse. And finally, when there is a deviation in genital hiatus or the perineal body, the shape of perineum would be changed or defective or become lax. Clear? Now, after measuring this point and diagnosing which compartment is affected, we are going to give a staging for the pelvic organ prolapse by this POPQ system. Okay? So, let's see how the staging is given by POPQ classification. Okay? Right. There are 5 stages here. Stage 0, where there is no prolapse, and apex will descend within 2 centimeter of hymen. Okay. Then you have stage 1, where the leading edge, descends to 1 centimeter above hymen. Okay. And then in stage 2, the leading edge descends to within 1 centimeter of the hymen. Okay, and in stage 3 we have the leading edge which extends above 1 centimeter beyond the hymen, but this lies less than 2 centimeter of the total vaginal length. And in stage 4 there is a complete eversion, and here the leading edge is going to be more than 2 centimeter of the total vaginal length. Okay, so this is all about the classification of POPQ system. In stage 0 there is no prolapse and the apex will descend, but it will be within 2 centimeter of the hymen. Okay, so let me explain this with the diagram so that you will understand it better. Okay, so for example, if we see a uterus, if we take a uterus like this, okay, then we also have the hymen. Okay, so the hymen is going to be the reference point here also. So first there is a descent, okay, but it will be within 2 centimeter somewhere here. Okay, so this is going to be stage 0. Okay, so this is going to be 2 centimeter from the hymen. And in the next stage what is going to happen is, this is going to reduce down and it is going to be somewhere between 1 centimeter from the hymen. Okay, so that is stage 0 and stage 1. Okay, and then in the stage 3 it is going to be within this 1 centimeter itself. Okay, so within 1 centimeter itself, like this, somewhere here within 1 centimeter, that is stage 2. Okay, and in stage 3 what is going to happen means, this is going to descend beyond the hymen and it will be lying within 1 centimeter beyond the hymen or 2 centimeter within the total vaginal length. Clear? Between the total vaginal length. Clear? And then is the final stage, that is stage 4, where it will be extending more than 2 centimeter of the total vaginal length. Clear? So hymen is taken as a reference point here also. Clear? Right. Now, let's discuss the various risk factors that will be leading to pelvic organ prolapse. When we speak about pelvic organ prolapse risk factors, the first and foremost factor that comes to our mind is childbirth. Okay, so this is a very important etiological factor, especially when she had frequent childbirth or she had a big baby, there was a history of prolonged labor, and when she had instrumental delivery. Okay, and the second important cause is menopause. Menopause means the factor which is going to affect to cause a prolapse is very good. It is going to be estrogen deficiency. Okay, increased age is also a risk factor. Obesity as well as smoking can also lead to pelvic organ prolapse. And not only this, any other surgical causes, like if she previously had a hysterectomy, okay, that can also be a cause. This includes both your total abdominal hysterectomy or total vaginal hysterectomy, and if she has a raised intra-abdominal pressure conditions, okay, like chronic cough or bronchitis or large abdominal tumors also, right? And finally, there is a chance that a nullipara can even get prolapse. So, a nulliparous prolapse is mostly seen after menopause, and it is mainly due to genetic disorders, okay, especially the connective tissue disease like Marfan's syndrome or Ehlers-Danlos syndrome. Clear? Right. Now let's see the clinical presentation, how they will present to you if a person has pelvic organ prolapse. Okay. So how will be the clinical presentation? See, usually these women will tell you like they have a feeling like something is coming out through their vagina. Okay, that will be the first and foremost complaint they will make it to you. Okay, so a feeling of something coming down per vaginally. Okay, some women can also complain of backache because there is a stretching of ligaments as the uterus is descending down. Okay, and then some can even complain about dyspareunia, or there can be difficulty in passing urine. Sometimes there can be incomplete evacuation also. So frequency of urination will be more in these patients, and this can be associated with cystitis. Cystitis is mainly because there can be urinary retention, and then there can be bowel symptoms as well. Bowel symptoms will include constipation and straining, and sometimes there can be increased white discharge or a blood stained discharge as well, that is going to be associated with decubitus ulcer or vaginitis. Clear? Right. Now let's see what are the changes that will be taking place when a woman has prolapse. Okay, so changes due to prolapse, especially in her internal genital organs. Clear? Yes. So first point is that her vaginal mucosa becomes stretched. It will become more thickened and pigmented also. Clear? And next one is, she can get an ulcer called decubitus ulcer, which means a trophic ulcer that is found on the dependent part of the prolapsed mass that is lying outside the introitus. So how this decubitus ulcer happens? See, there is surface keratinization. This will be resulting in cracks, and through this cracks there can be ascending up of the infectious organism that will be causing the infection, and at a point this ulcer will slough off and that will lead to ulceration. Okay, so this is all about decubitus ulcer. Okay, so there is surface keratinization, and then because of this keratinization the cracks will form through which the infectious organisms are ascend and going to cause infection, and finally at a point the infected area will be sloughing off and that will lead to formation of ulcer, which is known as a decubitus ulcer in a case of prolapse. Clear? Right. Now let's see what are the changes she will have in case of cervix. In cervix, usually the vaginal part of the cervix, okay, what happens means there is chronic congestion that will be leading to hyperplasia as well as hypertrophy of the fibromuscular complex. Okay, and In the supravaginal part, there is elongation. Okay, the supravaginal part is going to elongate. Clear? And the next one is bladder. Changes in bladder. In the bladder, there is hypertrophy of the bladder wall and the trabeculations are also seen, and there can be incomplete emptying of bladder that can result in, yes, cystitis. Clear? Right. Next one is about the ureters. In some cases, we will also see changes in the ureters where hydroureters will be seen. Clear? Right. Now, let's see what are the complications if a woman presents with pelvic organ prolapse. Okay. So, complications means there can be incarceration. Okay. Incarceration. That means there is infection of the paravaginal and cervical tissue that makes the entire prolapsed mass become edematous as well as congested. Okay. And the next complication will be peritonitis. Okay. So, there can also be peritonitis which can occur through the posterior vaginal wall. Okay. So, the infection will spread through the posterior vaginal wall. And yeah, there can be a chance of conversion of carcinoma also, which can develop from the decubitus ulcer. Clear? Okay. Now, let's see the differential diagnosis of this condition. Okay. So, differential diagnosis involves cystocelous Gardner's cyst. Okay. So, let's see what are the features of Gardner's cyst now. A Gardner's cyst is usually situated anteriorly or anterolaterally. Then, in the vaginal mucosa, the rugosities are lost. The margins of a Gardner's cyst is well defined, and usually a Gardner's cyst is not reducible and there is no impulse on coughing also. Okay, so this is how a Gardner's cyst is differentiated from the cystocele. Okay, first one, it is situated either anteriorly or anterolaterally. Then the vaginal mucosa, the rugosities will be lost over the cyst, and the margins of a cyst are well defined. It is not reducible and there will not be any impulse on cough. Right? Now, let's discuss about the uterine prolapse. So, uterine prolapse differential diagnosis is congenital elongation of cervix. Okay, first let us discuss this one. Let's keep it as A. Okay, congenital elongation of cervix means the vaginal part of cervix is elongated. Okay, should I stop? Should I stop? Okay. And the next one is this In this congenital elongation of the cervix, the external os will be lying below the ischial spines. Okay. The fornices will be narrow and deep. Cervix will be conical and the uterine body is normal in size and position. Okay. So, this is how a congenital elongation of cervix will be presenting to you. First one, the vaginal part of the cervix only is elongated. External os lies below the ischial spines. The fornices will be narrow and deep. Just imagine, if there is elongation of the cervix, the fornices becomes narrow and deep, right? Yes, that's what. Then the cervix will be having a conical shape, much conical shape, and the uterine body will be normal in size and in position. Only there is elongation of the cervix. Clear? So, this is first differential diagnosis of uterine prolapse, and the second differential diagnosis is a chronic inversion. Okay. Here, protruding masses broad, and remember, the cervix will not be felt separately and the uterine fundus will be seen outside. Okay. And the next point is fibroid polyp. Okay. Fibroid polyp means this will be presenting to you like a shaggy moss with a broad base. Okay, that will be acting as a leading point. Okay. And when there is a fibroid polyp, there will be no opening visible. Okay, but in case of prolapse, yes, you will be able to see the cervical opening. And then sometimes, yeah, the pedicle can be seen coming out through the cervical canal that is arising from the cervix. Clear? Right. Now, these are the differential diagnosis of pelvic organ prolapse. Now, let us see how we will be managing this condition. Okay. So, management, first we will offer them preventive measures. Okay. So, preventive measures. We have to offer a woman who is pregnant and going to deliver about the antenatal and postnatal exercises. Okay. These should be taught to the women. Okay. And there should be adequate intrapartum care as well. Okay. You have to give episiotomy at a perfect timing, and there should be avoidance of prolonged second stage of labor, and also you should do a proper suturing of episiotomy or even a perineal tear if it happens. Clear? Right. And not only this, you should also advise proper spacing between childbirth and there should be avoidance of strenuous exercise in puerperium. Okay. So, these are the preventive measures you will advise. We have to advise them on antenatal and postnatal regular exercises. Intrapartum care should be perfect, that is the timing of episiotomy, the suturing, and you should avoid prolonged second stage, and there should be proper spacing between the childbirth and avoidance of strenuous exercise in the puerperium. Clear? Now, let us see about the conservative management of pelvic organ prolapse. You should advise them on weight reduction, And yeah, pelvic floor exercise should also be advised. That is nothing but your Kegels exercise. Okay, and yeah, pessary is also a conservative management. The indications of giving pessary are: number 1, when she has no complaints. Okay, number 2, when it is only a mild or moderate degree of prolapse. Number 3, when it happens in very elderly women because they will not be fit for surgery mostly. And finally, when there is prolapse in a pregnant female. Okay, but however, pessary management is usually a palliative treatment. Okay, so the pessary usually stretches the vaginal wall and elevates the vagina. Okay, so as I have already told, this is usually given in women who are not fit for surgery and in women who decline the surgery or who is pregnant. Clear? Right. So there are 2 types of pessary. One can be a support pessary and other one can be a space filling pessary. Okay. Commonly used pessary is a ring type, that is ring pessary, that is made up of rubber or silicone, which is usually a support pessary type. Okay, and we also have gel horn pessary. This is a space filling pessary. Okay, let me show you the examples. This is a gel horn pessary. Okay, and this is a ring pessary with support. Okay, and this is a downward pessary. Gel horn pessary is usually a space filling pessary. Okay, whereas the other 2 types are the support pessaries, right? Yeah. So commonly, okay, with pessary we can also expect complications. Okay, so the complications of pessary usage includes: she may complain of vaginal discharge, there can be infection, ulceration, offensive smell that is coming from the discharge, there can be incarceration. Okay, especially in a forgotten pessary, sometimes the pessary change advice will be forgotten by the patient. Okay, then sometimes it can even lead to vesicovaginal or a rectovaginal fistula formation. Okay, and you have to remember one thing: you have to advise the patient about the pessary change. So pessary should be cleaned regularly with an interval of 3 to 4 days, and the patient herself should be trained about how to reinsert a pessary, right? Yes. Now let's discuss about the surgical management of prolapse. Surgical management of prolapse depends upon her age. Okay, for example, in a young woman with prolapse, if she has only mild prolapse and no symptoms, we would offer her, yes, pelvic floor exercise. Okay, and then if she suppose has anterior or posterior wall prolapse and there is no uterine descent, you can offer her pelvic floor repair. Okay. And in the third category of women who says their family is not completed, or she is a case of nulliparous prolapse, you can offer her abdominal sacrohysteropexy or a sling operation. Okay. And the fourth category of young women will be who says their family is completed, but they also wants to preserve their uterus. Okay. So, in that case, we will be offering them a surgery called Fothergill's operation, or we can offer them sacrohysterocolpopexy. Clear? Now, let us see what are the options available for elderly women, surgical options. Okay. So, elderly women means, so the first class of elderly women will include who are symptomatic and those who have completed family. For them, simply offer vaginal hysterectomy with pelvic floor repair. Okay. And second one, if you offer for a, and the second category is when they are symptomatic and they have procedentia, you have to offer them definitely vaginal hysterectomy with pelvic floor repair, but additionally you have to do sacrospinous colpopexy as well. Okay. And the third category includes females who are unfit for surgery, as well as they are not desirous of sexual intercourse as well. Okay. For them you can offer an operation called Lefort's operation. Okay. And the fourth category of elderly women will include those who have associated stress urinary incontinence. Okay. So, for these people you will offer TVT or TOT, okay, that is transvaginal tape or transobturator tape, or a bulge colpo suspension. Okay. Also, you can offer them sling surgeries like Schirotker's sling surgery or Kanna sling surgery. Clear? So, yeah, we have completed pelvic organ prolapse. I have just explained about the names of the surgeries which should be given and in which group of people you will be giving these surgeries. Okay. For UG level, you need not go into detail about how these surgeries are performed, what are the indications, contraindications, and all. Okay. So, only you know for what category you will be offering what type of surgery. That is enough, right? So, with this we are completing our discussion on pelvic organ prolapse. I hope you found this video helpful. So, until we meet in the next video, take care, happy learning, keep going, and bye-bye.